Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, hello there, wonderful listeners. Happy Friday, right? This is Friday TGIF, and I'm back from some of my travels. You probably didn't even know I was traveling, but I'll tell you all about it in subsequent episodes. But today, I'm thrilled because today we are doing something that I've been thinking about doing for a very long time. For a very long time, I've been thinking about bringing an expert who can tell us about the hormones. Now, you have heard this all over the place. Menopause, andropause, should we use the hormones, bioidenticals, not bioidenticals, whatever that is that you have heard of, please put your biases and your misconceptions to the side and open your minds and your hearts for Dr. Lorraine Maita, who is absolutely the star hormone expert that provides this level of intervention to multiple patients highly successfully. Welcome, Lorraine.
Well, thank you for having me. And I'm here to bust the myths because they are out there. They've been out there for a long time, even before this whole misinformation stuff came along. It's been around for a very long time. So I want to bust the myths because they're safer than you think.
Excellent. So I love this. So the theme of this episode is that hormones, they're safer than you think, right? So let's get right into it. But maybe first tell us a little bit about yourself, because you kind of had a very interesting career arc, a lot of accomplishments in that career arc, and you're still climbing to the higher heights. So tell us a little bit about who you are, how you started, where you've been, and, how did you grow up to be a hormonal expert?
Well, when I was in, just deciding about medical school, I worked under one of the leading experts in IVF, in vitro fertilization at NYU Medical Center. And that was when it was brand new. And I fell in love with hormones. But when I came to becoming an OBGYN and going through interviews, most of them were crying and they weren't happy. And what a few people counseled me on is like, do something. If that's the only thing you like to do, then do it. But if not, there's so many other things to do. So I decided to take the internal medicine track. And when I worked in a big company, I worked in the emergency room. I ended up with tuberculosis.
Wow.
Yes. And I had to be on antibiotics for 9 months. So after that, I cured the tuberculosis, but I was a mess. I was gaining weight. I was having rashes. I had yeast infections. I was losing my hair. I was tired. I had brain fog, and I didn't know what to do. And that's how I discovered functional medicine and how the gut is so important for your overall health. And it was like, oh my God, it works. I'm myself again. So
I fix me, right?
It was like, hey, if this happened to me, it's going to happen to other people. So under the table, I learned about this stuff. And I was the first to take the IFM course when it was under Jeffrey Bland. And I had the privilege of meeting him. I was his first graduating class. Wow. So after the emergency room and the whole stint with tuberculosis, I worked in a company, and here I was like, I could save your life, right? I could just like bring you back to life. And a woman comes into me and she said, then back in the day, there were very few high-level executive females, very few. You can count on one hand. And she came down to me, and it was very intimidating because I was still quite young. And she said, you have to help me. I was standing giving a lecture, and all of a sudden I broke out in a hot flash. I felt the heat. The sweat was pouring down my face. I lost my train of thought. The men were either looking down and casting their eyes down in shame or elbowing each other, snickering. And she said, how am I going to be taken seriously? You have to help me. So it was like, oh, Okay.
Wow.
I could save her life, but I didn't know anything about
But
menopause.
you could also save her career, which is,
Right. And I did. So back to NYU with all the hormones, I did a lot of stuff on hormones there. So I started recommending bioidentical hormones when it was new. Nobody knew about this. And I trained under some people there, and women would come down. I was sort of like, did all this, sort of under the
undercover. You did the undercover. I love this. Undercover, undercover hormonal doctor.
Oh,
Okay.
I was, because you couldn't talk about this stuff. People would say, "Are you practicing alternative medicine?" I'm like, no, this is common sense.
So let's stop it right here. So why, because our listeners may not know, right? Physicians probably know, but our listeners may not know. Why could we not talk about this stuff? What was going on in medicine at the time, specifically with regards to hormonal therapies, hormonal replacement therapies, or HRT, as it's commonly called? What was going on at the time?
At that time, that Prempro was big. And they were doing a study. Then it was okay to give hormones, but nobody knew about the bioidentical hormones. And what happened in this company, the people on Prempro would come down and they didn't feel as good. They had depression, they had a lot of breakthrough bleeding, and the women.
So the Prempro, let's just reframe it, right? If I recall correctly, there was something called YS Pharmaceuticals, right?
Yeah.
YS Pharmaceuticals. And there was this notion, and this was honestly before I was just beginning in medicine, perhaps in medical school. That was sort of happened, even before that. There was a sort of a mechanistic concept, right? The idea was, here are women, they go into menopause, the estrogen and progesterone wind down, and we start seeing issues like weight gain, hypertension, coronary disease. They sort of the prevailing wisdom at the time was they're catching up to guys, right? They're sort of they're almost like turning into guys, right? And so YS Pharmaceuticals came out with a synthetic medication, Prempro. So you'll have to explain what Prempro is. Right. And I remember being, I think I was an intern or a resident, and I remember our attending tell us that, when a woman comes in, if she is in her 50s, menopausal, you need to start her on Prempro. And that was the wisdom of the day, right? So what was Prempro? What was in it? And, what have you seen with it?
We also gave Premarin, which was synthetic estrogen given orally, made from horse urine, and Provera, which is a synthetic progestin. So what Prempro did is they combined the two. Right. And that became the big deal. But during that time, it was almost malpractice not to give women hormones.
Correct.
I worked in a big company, and that was the highest prescribed drug, Premarin and Provera and Prempro. But during that time, when they didn't have oral micronized progesterone at the time, they didn't really know how to formulate it. But the standard of care was Premarin, Provera, or Prempro, and those are the brand names. So what we learned after that is then the Women's Health Initiative came out, right?
Right. So that watershed moment, right?
Oh my God.
I want our listeners to understand, right, that the hormonal therapies, specifically for women, because men really didn't have these type of studies. They had some studies, and I think our idea on testosterone is also changing right now. But for women, we sort of went from here to 180 degrees. Yeah. And I literally remember being in my clinic as a resident. And if you recall, as a resident, right, you have an attending who supervises you, and being called to this attending's office. And I'm thinking to myself, I must have done something really bad, but all the patients are happy. So I don't know what I've done bad. And he was very serious. And he was like, I want you to call all of your patients and stop all of your hormonal prescriptions. And, like right now. And so that was Women's Health Initiative. So tell us about what happened.
So what happened with the Women's Health Initiative is the study was hijacked, right? So the press got a hold of it and, publicized that it increased the risk of heart attack and stroke, and it increased the risk of breast cancer. So they stopped the study, and then all women.
Well, so first of all, what was the study? If you could just tell us briefly, what was the study? Who were those women? What they were given? And,
So this study was really designed to see how long after menopause can you give hormones, right? It wasn't designed for, seeing how safe hormones were or when was the best time to give it. So it was given high dose synthetic hormones to women whose average age was 63, 10 years past menopause. And what I say to people, by that time, the ship has sailed. Like a lot of damage has been done. And not to say you can't reverse some of this damage, but a lot of damage has been done. They didn't look at lifestyle. They didn't talk about lifestyle. They just they just studied. It was a very, very big study. That's why they continue to study this study.
Right.
Continue to quote this study because it's so hard to get people to be in studies, and it's so expensive to do a study. They're taking that study and they're over the years have dissected it. And they started looking at, so the press got a hold of it and it was like, oh my God.
Well, the premise also, let's just remember that the premise in that study, right, was also to see whether hormones, because that was one of the situations, was to ascertain if the hormones were actually protective for cardiovascular system, right? So some of the endpoints that were studied were blood clots, heart attacks, strokes, and of course, breast cancer, right? So that's sort of, it was meant to be a study that would, for lack of maybe better word, put a definitive proof that what we thought was supposed to happen, which is when a woman goes into menopause and you replace her hormones, that it's actually good for you. So we wanted, the scientists, and that I think was, one shouldn't probably minimize the fact that, that was a fairly good question to ask. What are the outcome studies? And that was actually in the age where outcome studies were not the norm. Right. This in many ways, women's health study was a study that really put out their outcome measures as relevant measures for scientific research. So what did they find in this study that was concerning? And as you said, heavily promulgated in the press?
Well, they found 8 more cases of breast cancer and an increased risk of heart attack and stroke, which is why they stopped the study.
Okay.
And, we learned a lot since that study, but that is fixed in people's minds, even to this day. That study was done in 2002. Now, one of the things that we learned, because at the time, all they had was oral estrogen. Mm-hmm. And they had oral synthetic progestins. But what we know, if you take it by mouth, oral estrogen, it goes through the liver, and the liver makes clotting factors, so you have increased risk of clots. And clots can break off, and if they break off and go to your brain, you get a stroke. If they break off and go into your heart, you get a heart attack, but they can break off and go anywhere. So you can get deep vein thrombosis, but you get the same thing from the birth control pill. So people do not even bat an eyelash when it comes to being on birth control. But these are also synthetics, right? They're synthetic.
Mm-hmm. Yeah.
So the world has changed. Drug delivery has changed. The way, the timing, the dose, and the form seems to make a difference. So what they found is that now they started making patches that go on the skin, right? So estrogen can be given through the skin, like alternative medicine used creams. They had compounding pharmacies making creams. And we know that the drug delivery through the skin does not cause clots. The risk of clots is negligible. So that risk of heart attack and stroke went way down, right? You just don't find it when you're giving estrogen through the skin.
So let's summarize this a little bit, right? So the Women's Health Initiative, the problem with the Women's Health Initiative, something that we learned subsequently, it wasn't obviously apparent at the time, is that the replacement therapy, and at the time the bioidentical or biocompatible therapy wasn't really available. Replacement therapy resulted in increased risk of events, right? So coronary heart disease events, MIs, strokes, venous thrombosis, as well as somewhat increased risk of breast cancer. And certainly it decreased other things, which were fractures and colorectal cancer. But the study was stopped early, something that sometimes the studies do, because this is either they do it because the benefit is very significant, or they do it because there is a safety signal, right? So that is very significant. Right. So that was very significant. So we didn't really finish the study, but it was stopped early because there was this overall harm signal. And just as you're describing, that had given rise to a lot of stigma with regard to using hormonal replacement therapies, specifically in women. And, official cardiology position remains that hormonal replacement therapy is associated with more risk than benefit. I remember, a number of years back, having a conversation with a very well-known women's health cardiologist, and we were both faculty members at a national meeting. And she told me, she said, you can't even talk about hormonal therapy because, that's asking for malpractice. And I knew already at the time, just like you, I sort of ventured into the functional medicine and the integrative medicine and started building a more comprehensive, holistic approach to our patients. I knew at the time that she wasn't exactly right? So what have we learned since the Women's Health Initiative trial? Because it was such a fundamental trial, and it still, had meta-analysis and sub-trials, because there were a number of lessons that we learned from it that nowadays are actually paving the way for the new phase of the hormonal therapies in women, right?
Yes. Yeah, what we learned from that, sorry, I'm losing my voice. What we learned from that is that if some of the women had a hysterectomy, and the school of thought is if you had your uterus removed, you didn't need progesterone because progesterone was only to protect the uterine lining so that you don't get cancer of the endometrium, meaning of the uterine lining. So when they gave estrogen alone, the risk of there was no increased risk of cancer. There was actually a decreased risk of cancer in estrogen alone. In synthetic progestins, that seemed to be the culprit to increase the risk of cancer. And they also saw that, you compare a group of people getting the hormones with a control group, and the control group is supposed to be representative of what's out there in the population, right? But the control group actually had a lower risk of breast cancer than the general population. And so it looked like the risk of cancer was increased, but the people on hormones had about the same risk as the general population. But because they were comparing it to a group with a lower risk, it seemed that the risk was higher. I mean, does that make sense? It seemed like the risk was higher, and there was only 8 more cases of breast cancer. So we learned that it wasn't the best control group. It wasn't the best comparison. Estrogen alone did not cause breast cancer. Synthetic progestins did.
Right.
And they also noticed that if you gave it before age, younger women before the age of 60, within 10 years of menopause, the benefits outweighed the risks. So,
Right.
You have to, the sooner you start, the better. And I've even learned that, you're better off starting some things in perimenopause,
So interesting. So very interesting, right? So I think the study gave us, even though the impact was kind of closed the door on hormonal therapy, it turns out it was much more nuanced, right? We learned that there is a certain window of opportunity, or, the hormonal window, if you will, certainly for women. We know now from the functional medicine perspective that this window is not, at least you work with a lot of patients, and so do I, it's not set in stone, right? We have women that are, they need it in their mid to late 50s. And there are some women who may even be starting in their like mid to late 40s, rarely a little bit younger than that, but it's possible. We learned that there are different forms of the hormonal replacement, right? So let's, you're an expert and a myth buster. So let's go and bust some of those myths. And of course, this discussion could be like a whole day discussion.
Yes.
But we are going to try to consolidate it so that our listeners actually understand, what is the verified, reliable information and what the thinking process is right now in 2025 with regard to hormonal replacement, right? Because we now have Menopause Society, we have practitioners who are certified by Menopause Society, and, menopause and, as a obvious sort of package of menopause, hormonal replacement therapies have become sort of part of our vocabulary, right? People talk about them quite openly now. So be my myth buster. Based on all these studies, what is the number one myth that people usually think is real, but it's actually false?
They think it causes breast cancer. So even the Women's Health Initiative, they decrease risk of breast cancer, estrogen alone. Subsequent studies show oral micronized progesterone, natural bioidentical progesterone, not the synthetic, is safer. Some studies show it actually decreased the risk. Some showed no increased risk. Some showed maybe a very slight, rare increased risk after 5 years. But the great majority of studies support natural bioidentical progesterone is safer, right? And natural bioidentical progesterone does not, like the synthetic form, negate the positive effects of estrogen on the heart and the blood vessels. So the breast cancer risk was the main one. The second one was the risk of cardiovascular disease. But we know if you give estrogen through the skin, you don't have a risk of heart attack and stroke. And I don't know if you got the latest study. I'm not sure if I sent it to you. They just did a study in Sweden. The women, once they changed the way you gave hormones, the risk of ischemic heart disease decreased by 50% in women on hormones. And the longer you're on them, the better, right? So that's a game changer. So we now know how to give the hormones. We did learn that giving them earlier is better. But we also learned that you can give them later in life. Now, the risk for heart disease later in life is a little bit different because once the arteries are really hard, that's not as easy to turn around. But I give it to women who have memory problems. I give it to women who have osteoporosis. And now the North American Menopause Society and at least 20 other organizations finally came out and said the benefits outweigh the risks. And that is a game changer. So the risk of breast cancer is not there. You give it the right timing and the dose and the form, you don't have the risk of heart attack and stroke. Natural bioidentical hormones do not cause coronary artery spasms like synthetic progestins do. They do not cause gallstones like synthetic progestins do. They don't increase the risk of diabetes. They don't raise blood pressure. They have less side effects because some of the progestins are androgenic, meaning they're like male hormones, and women get acne and have hair loss and they get oily skin. So the natural bioidentical progesterone is the same identical progesterone that your own body makes. And it's a matter of dosing where you're at the most comfortable level that decreases symptoms and that gives you a quality of life.
Hi everyone, it's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol, then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is owner20, and I'll see you in the office hours. So there are a couple of things here that you're hitting kind of on some really, really important points, right? So number one, of course, is individualization of therapy.
Yes.
And individualization of therapy, at least from my perspective, because I deal a lot with cardiac patients, also requires appropriate risk assessment. So, and there are gaps in our knowledge of risk assessment, but don't necessarily have the answers to all the questions. But, in the study that were done, like Women Health Initiative, some women had coronary artery disease, but there was no assessment for subclinical coronary artery disease, for example. It really, it exists at the time, it existed, but it wasn't really widely used in clinical practice because, we had a BCT. I think we already had more of the agates and calcium scores in 2002, but, but it wasn't really sort of part of the practice, wasn't as accessible. Another part that I'm sure you're doing is that, the breast cancer risk is the fact that we are seeing breast cancer rise, especially in younger women, right? It's a totally different, I think, association than the breast cancer that we're seeing in older women. And the role of hormones is a bit in the gray area because some of the issues that we're seeing with these breast cancer rates, and they're different from country to country, are the toxic exposures, right?
Yes.
So we don't know exactly how these interactions between hormones, which are bioidentical, and the toxins, how does that pan out, right? We learned of this timing window, especially for cardiovascular benefit. That timing window is so important. Starting the hormones, or at least considering hormone therapy before you have hypertension sit in, before you have dyslipidemia, before one has a full-blown metabolic syndrome, or, what I called sort of like occult insulin resistance, which, a lot of patients have, right? So this was important. The forms of the hormones, right? So the, how they're delivered. So you busted our first myth, hormones causing cancer. What would you say is the myth number 2 with regard to hormones?
A lot of women say to me, "Oh, hot flashes, they're going to go away. I don't have hot flashes. I don't need hormones." Or I have hot flashes and I can live with that, right?
Okay.
Well, hot flashes are a biomarker of something else happening in your body. And hot flashes increase your risk of cardiovascular disease, dementia, bone loss, and inflammation. And inflammation is the root cause of most chronic conditions. And we age from inflammation is inflammaging. So, I did a deep dive study in hot flashes and all the implications. They're not benign. So that's like your check engine light. And if you look at the check engine light, it means there's something wrong inside. And if you ignore it, something's going to break down. So hot flashes are like your check engine light. There is something wrong, and it's the lack of hormones. You lose bone, you lose memory, your lipids go up, your risk of cardiovascular disease go up, your metabolic syndrome risks go up. But it's the quality of life. How many women come to me say, "I'm tired, I can't sleep, I have brain fog, and I'm gaining weight. Those are the top 4 reasons women come to me. And it's all because of hormones. And
Mm-hmm.
when a woman came to me and she said, my husband said I'm unbearable. I really, husbands find me for their wives because they know something is wrong, and it's an act of kindness. Like, I need to help her and I don't know what to do.
What
Can
to
you help
do?
my wife? Can you help my wife? And they come in together and I explain, and I get a lot of head nodding. I get a lot of head.
Like I'm doing right now, right? So if you're on video with
Yeah,
us, I'm nodding. So this is a fantastic point, right? And I think it is better that we iterate it again, because hot flushes most of the time, are considered benign, right? And, we typically, like, I think even traditional doctors or over-the-counter preparations, there's a lot of stuff that's being marketed for hot flashes, right? There's a lot of stuff that it's sort of like, oh, just take this, it's herbal, it's known to decrease the hot flushes. So it sort of minimizes the whole hot flushes as an occurrence. But as you're pointing out, and as I had seen in my patients as well, hot flashes are a marker of an instability in
yes.
cardiovascular system, right? This is, people become very concerned when they see their high blood pressure or blood pressure numbers go into the abnormal range, right? Whatever stage hypertension that might be.
Yeah,
I think women should be just as concerned when they start experiencing multiple hot flashes or even a single hot flash, because the origin of it is actually very systemic, and it's going to reverberate and affect the cardiovascular system. And some of those changes in cardiovascular system, and additionally, cardiometabolic part of it, will become irreversible or will progress, right, to the point where they need more of a intense or medical or even prescription intervention.
right. Exactly. So hot flashes are not benign. And, the other, there's so many misconceptions about the risks and also what menopause is. The definition is 1 year without a period. But what we really don't understand is there are about 35 symptoms of menopause. The lack
Mm-hmm.
of estrogen and lack of hormones affect your memory. They affect your oral microbiome, the bacteria in your mouth that keeps your gums and teeth healthy and
Mm-hmm.
also protects you against respiratory infections. There's burning mouth syndrome. There's more dental caries. There's it changes your gastrointestinal tract, gas, bloating, belching, and
Wow.
flatulence.
And I add, labile hypertension,
Yeah.
and the first early lipid abnormalities. If a person had normal lipids before, let's say normal cholesterol, optimal or fairly optimal numbers, we are beginning to see what is typically, I would describe to my patients as a metabolic pattern, right? In those lipid labs, right? So this is very interesting. And it's probably not, and it is, I think it is a myth, although this is how the medical societies put it, right? So menopause is 1 year without a period. And I hear patients say it all the time, or I've been that many months or that many years without a period, I must be in menopause. So you busting this myth that menopause is so much more than 1 year without a period. It is.
Yes.
Right. So that brings me to, so let's summarize what we learned so far. We learned that hormones are not the cause of cancer, right? It's inappropriate to think of hormones as causing cancer. That's actually not true. Now, obviously, there are some cancers that known to have hormonal associations, specifically breast cancer, but it doesn't necessarily mean that hormones are causing breast cancer, right? So that's so right. So we learned that. That's a myth buster. Number two, what we learned is that hot flashes are not benign, because while they may not necessarily be something that, acutely imperils you, they're a sign that the cardiovascular system is off, right? Your neuroendocrine, your cardiovascular system is off. And so, it's a beginning of the cascade that if it's not checked in, like you said, that engine line, if there is no recall,
Yep.
you may end up having a breakdown on the side of the road, right? So
And it
that's
affects your brain and your bones and your
exactly
aging.
systemic. So hot flushes are a marker of systemic effects of aging, including hormonal aging, inflammation, and the vascular response. That's what they're looking at. And finally, myth number three is that menopause is 1 year without a period. And as you said, menopause is so much more than that. It is really a very complex subclinical and sometimes clinical syndrome that women are experiencing, and very often not realizing that this is what's happening in their bodies, right? Because the symptoms could be attributed to something else. So great myth busters with Dr. Lorraine. So Lorraine, what is your approach? Let's say a woman like me. Let's take me here. I'm in my mid 50s. I actually let's assume I'm in menopause, and traditional definition. I'll come to you and I say, Dr. Lorraine, what should I be doing? So what should patients be doing? What you ask them to do? And again, I realize this discussion could take days, but
Yeah.
how do you assess women, and how do you safely begin hormonal therapy? What are the guardrails of the hormonal therapy?
Well, I always educate my patients. So anybody that comes to me is going to get a synopsis of the hormone studies, because they're going to get pushback from whether it is be family, friends, or any healthcare provider. Oh my God, you're on hormones. You shouldn't be on hormones. I had doctors call me and start yelling at me, and I have a paper for everything, Regina. I can cite any study, and how do you know? Listen, I have 30 years experience, and I write blogs every week and cite the literature, and I've been doing this for a long time. So
let me stop you for a second. If people go to Feel Good Again Institute, they will get those blogs, like some of your information or a course, or what are they going to get?
Well, I have a course because it's part of my assessment. But if you want to know, are hormones right for you? I have a course. Is hormone therapy right for you? So that's going to take you through your own self-assessment, the assessment I'm going to do. What is your quality of life? What symptoms do you have? Women come to me and say, I just don't feel like myself anymore. I feel like somebody pulled the plug and I have no juice left. My life went from technicolor to black and white, and I feel flat and dull. My sex life is poor because you have more vaginal dryness, painful sex, more urinary tract infections. So I want to know, how is this affecting your quality of life? Can't sleep, you're gaining weight. So I check the boxes. What symptoms are you having that could be related to hormone replacement? Is hormone replacement
or lack of hormonals that could improve with replacement
exactly.
therapies?
And then what is your quality of life? Because when it also starts in perimenopause, I got deeper into it because during my perimenopause, I was tired, irritable, couldn't sleep, gained weight, and I pissed off a lot of people. Not because I did or said the right things. People said to me, my best friend said to me, your personality changed, because you would choose the right words, but there was a level of irritation there, and the irritation came from fatigue and lack of sleep. And she said, you just sound like you're mad at me all the time. And I'd walk into the office and people would go like, what mood is
she? She's back. She is back.
That was very hurtful because that's not me. And that you have to see how it's impacting your life. Could these symptoms be related to lack of hormones? What are your risks of not taking hormones, right? Do you have a family history of dementia? Because hormones, you make estrogen and progesterone in your brain, and testosterone as well. And they modulate the inflammation in your brain. They modulate your brain feeling
And in your blood vessels, they
And in your blood
modulate
vessels.
the inflammation in the blood
Yeah.
vessels. There are countless patients that I had seen that once they're replaced appropriately, we actually achieve blood pressure control.
Yeah.
So,
So we look at the risk of dementia, risk of osteoporosis, risk of cardiovascular disease. Of course, I am going to measure because a lot of these symptoms could be other things. That woman who said, my husband said I'm unbearable, she went to 8 different doctors for different things. She was
mhm.
achy, joints ache, your gastrointestinal system goes awry. You can't think, your lipids go up, your blood pressure goes up, you're gaining weight, all of that. So, I try to put all the pieces together. So, what are the risks of not taking the hormones? And then what are the risks of taking the hormones? So we now know giving estrogen through the skin does not increase the risk of heart attacks and strokes. Estrogen does not cause breast cancer. Natural bioidentical progesterone is safer. And the main reasons why I wouldn't give somebody hormones, and this is also questionable as well,
Mhm.
if you have a history of breast cancer. Now, I know some colleagues that feel comfortable. I won't do it unless I study it to death.
Right,
Because
right.
I don't study it to death, I'm not going to experiment on you. But I know many people who do give it because we know it does not increase the risk. But I don't give hormones to somebody with breast cancer, history of breast cancer, active breast
And
cancer.
neither do I, because I think those patients might be in a different category, right? There could be processes in those patients, and usually we could find, from the functional medicine perspective, as you know, we may find that they are not really clearing their hormones in a safe way, that they have toxic
Right.
overload. So it's not necessarily the same patient group. A very important point here, and I'm sure you ask about it in your patients all the time, is that I'm very rigorous in my patients with regard to the screening studies. So I always ask for an annual mammogram, and usually
Yes,
it's a
yes, yes.
mammogram and an ultrasound. There are some patients with very dense breasts, for example, they have breast MRI and the mammography. And so we have such great techniques right now with regards to picking up even the teeniest, tiniest breast cancers that, screening is really super important,
Yeah.
for anyone considering hormonal therapy or who is on hormonal therapy. So that's really a key factor.
Yeah. So the people that I don't give hormones to, somebody who's already had clots or
Hmm.
pulmonary embolism, and some of the like BRCA, they're a little
So
more
the
genetic.
genetics, which
Yes.
is adverse. Are you using this sort of the breast cancer risk calculator? And let's say, I think it's called, I forget, it's a double name either Toreg or Twasik. I'm going to look it up actually for our listeners so that they know what it is. Are you using it at all to
No,
calculate their risk?
no, because what I do is I make sure we check all the boxes to
Hmm.
decrease the risk because it not only decreases the risk of breast cancer, that's why I'm called the hormone harmonizer and detoxifier.
All
You're
right.
right on because I detox and decrease inflammation in every woman who comes to me before I start the hormones. So within 2 weeks, 80% of people feel good to great. I do
Excellent. So
a
this
two
is
week.
so this is let me just stop you for 1 second so that make sure that everybody knows it. There's something called Thyrer-Cusick risk assessment calculator. Thyrer-Cusick risk assessment calculator. And if you're a woman listening to this, it's available online. We'll put a link to this in the show notes. You can quickly calculate your risk of breast cancer. This is actually also used in the imaging facilities, for example, when you're getting your mammogram or you're getting your ultrasound. So, talk to me about detoxifier. What does it mean, and why is it important for the hormonal therapies? You being
Everybody,
master detoxifier.
well, everybody does a detox differently. So I have people arguing with me. Oh, I did the detox. I did the whole 30. I did. It's, decreasing the amount of toxins coming in. So eating clean, clean water, clean produce, eat the dirty dozen organic, hormone free, antibiotic free meat, poultry, dairy. Over time, because I don't want to overwhelm people, As you start running out of products, personal care or cleaning products, choose cleaner products. Don't heat in plastic.
Mm-hmm.
Plastic is our enemy. They're finding plastic
Yep.
in people's
Yeah,
brains.
I know. There's lots of podcasts and articles about microplastics. I mean, listen, there was an article I think last year about microplastics in the carotid artery plaques.
Yes,
It's just mind
it's all
blowing,
over. It's
mind
all over.
blowing.
So
Okay.
cutting back on plastics is big, and it's, I put everything in glass containers. Even when I used to go to Starbucks, I brought my own cup or I asked them for a cup. Even those paper cups are lined with BPA. We know they're hormone disruptors. And ladies, you're always worried about weight. They're
Yeah.
obesogens, meaning they make you gain weight, right?
Yeah.
So I teach people how to decrease the toxins coming in, and I use a certain formula to help the liver increase the toxins coming out. And usually it contains milk thistle and Jerusalem artichoke and N-acetylcysteine or glutathione. And that helps you detoxify, right? So
Mm-hmm. Mm-hmm.
the other piece I do is I decrease inflammation. It's a root cause of
Okay.
aging. Because I studied anti-aging and regenerative medicine, right?
Exactly.
And I'm an internist, so I can't just focus on one little thing. I have to do the whole picture, right? I have to do the whole picture. So whatever I'm doing is not only going to help your hormones, it's going to help everything, your brain, your bones, your joy of life, right? Help with the aches and pains and all these other things that cause inflammation. So I have people do a very quick 2 weeks elimination diet, right? And you eat
Mm-hmm.
paleo style, and I use a shake that decreases inflammation in the gut. 80% of your immune system's in your gut.
Is in the gut.
In
Exactly.
the gut, right? So we want to have your gut nice and calm and healthy. And, also women who don't have a gallbladder, I make sure we get bile flowing
Right.
with digestive bitters or TUDCA, because bile is antiseptic for the beginning part of your gut. And it also binds the breakdown products of estrogen, some of which the breakdown products can be toxic.
Okay, so on that topic, right, there is a lot of, you and I are in the same sort of functional integrative medicine community. There's a lot of conversation and a lot of lectures on actually testing for the hormonal metabolites, testing for the hormonal metabolites, just as you mentioning, you're detoxifying them, but some of those metabolites, some of those byproducts as hormones break down in a person's body could in and of themselves circulate back and contribute to, hyperexposure, right? Undesirable effects. So are you testing for these metabolites, and are you making your treatment decisions based on the
Yes.
information?
Yes. The big mistake that I see is when women don't really have much estrogen. When you do the Dutch test, which is it's a fairly expensive test, it's not going to be as accurate as if you were on hormones. So
Correct.
every perimenopausal woman, anyone with PMS, anyone with high levels of estrogen, I do it right away. In other women, if women with a history of breast cancer, I'll do it right away because we're not going to give them hormones. But women not on hormones whose estrogen levels are low, I wait till we get it replenished. And I
Mm-hmm.
want to see, just picture your liver as a recycling plant. It's going to separate the clean recyclables, which are benign breakdown
Mm-hmm.
products, with the semi-toxic and the very toxic. So we can see that in the test. You make a lot of the toxic. If you do, I give I3C, indole 3
Mm-hmm.
carbinol, and DIM, diindole methane. It helps you make more of the non-toxic. Now, just like any garbage, you have to package it properly for the garbage man to take
To
it,
take it out,
right?
exactly.
Well, if your body doesn't methylate, that's like putting it in a package,
Mm-hmm.
neutralizing it so that it doesn't stink up the house, right? So it doesn't get reabsorbed into your
Mm-hmm.
system. Then I want to see, can you methylate? Because if you can't methylate, you're
You're
taking,
not going to clear it out. Yeah.
you're right, and you're going to reabsorb those things. And my other pet peeve is constipation.
Yes,
You
constipation,
know,
because
Yeah. I tell people, if you do not move logs and snakes every day, it's like flushing a backed up toilet. All that
Hmm.
stuff you want to get rid of is just going right back into your system. So women who tell me, oh, my bowels are normal, I go every 2 or 3 days, and they're like little balls. No,
No.
no, no, no. I make sure you get fiber. It binds the toxins and it removes them. And you got to move the logs and snakes every day. And women have told me, I never felt better in my life. I never, but you have to be careful. You have to do the
Sure,
fiber.
you have to do it stepwise. You
Right.
have to be consistent and compliant and coachable. So this is one of my pet peeves right now is that we see a lot of, as you know, I'm very active in digital health tech, and I love startups, I love platforms, and we're seeing a lot of companies right now that are coming after menopausal women market, right? And they're coming into that market with a very specific message, sort of sign up with us. We're going to give you hormonal replacement therapy. Your other doctors are not giving it to you, or they're hesitant. They don't know how. And we're going to give you some health coaching and some maybe nutritional guidance. So it is a interesting step. And I think perhaps it's a step in the right direction. But, it is not really, I have not come across anyone yet or the platform yet that really afforded this level of clarity and individualization that you're describing, right? Because anyone could send a script for a estradiol patch and prometrium to a local pharmacy, but to really put it together in this personalized way and to understand, does this person need an adjustment with regard to how their gut works, their immune system works? Do they
Right.
need to be detoxed? And I think what you brought up, the fact that detoxification is such an impactful and important
Yes.
part of hormonal replacement therapy. So I feel like a lot of the times women, they don't know it, so they're leapfrogging over it, right? They want like replace, but we're trying to tell them that first there are certain things that you need to remove and repair, right? so
That.
so and so I find that we in functional medicine are taught this 5R system for the gut, right?
Yeah.
Remove, replace, repair, reinoculate, rebalance. But if you think about it, this 5R system is actually, it's foundational because it works for everything. Because
Yeah.
the first step is to
Yeah.
remove. You don't just hop over it into the replace. So I think this is a super important statement that you're making. So what would you say after they've gone through or beginning stages of the protocol? What are you aiming for? Sort of, what are your goalposts? Are you measuring estradiol in the blood?
Yeah.
You have a certain number. So kind of what are the milestones, if
I
you will?
do, I start off while I order very detailed blood work because I want to look for metabolic syndrome. I want to look for
Mm-hmm.
inflammation. I want to look at all your hormones because
Mm-hmm.
every hormone is going to affect every other hormone, right? So I'm going to order detailed blood work, and something that I do cortisol in saliva because
Mm-hmm.
cortisol, the hormone of stress or distress, which could be physical, emotional, or chemical,
Mm-hmm.
is going to impact all your other hormones. You could do
Yep.
everything right. And if your cortisol is off, you're a mess, right? You're a mess. Not just your hormones, your immune system, your nervous system, your hormone system. And I have to make sure I check all the
All the
boxes.
boxes.
We're doing the detox and elimination while we're waiting for the tests to come back. When the tests come back, I ask what got better, what didn't get better, what foods did you react to. We do a medical symptom questionnaire because people are surprised that they have minor symptoms that they've learned to live with. It's like
Mm-hmm.
their normal. It may not be optimal, it may not be normal, but it's their normal and they think it's normal. So they do a symptom questionnaire before and after. And I've seen scores drop because the more severe and the more symptoms you have, the higher the score.
Mm-hmm.
You want the score to be lower.
So after the detox, you mean the
Right.
scores are decreasing? Okay.
So we want to address what people come in for. Doctor, I don't feel like myself anymore. I don't have the energy. I'm not sleeping. I'm gaining
Mm-hmm.
weight. I have brain fog. So, mood, energy, weight, and the symptoms of hormones. So we want to see those symptoms subside. And then giving the hormones is the icing and the cherry on top.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Card Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticcardcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. Right. So that's exact. So that brings back that point, right? So replacement is actually, the power of replacement is truly realized when the context in replacement is great, right? And once a person detox, and we use a little bit of a different approach. We don't use elimination diet, actually use something called fasting mimicking diet. So that's, that is a very easy, and sort of very specific way, and it is detoxifying because for a number of reasons. So you're using the fasting mimicking diet. It's one cycle, which is 3 months, is what patients go through, and that's really all the other interventions get augmented manyfold when there is an appropriate substrate, when you're not fighting your own body to actually to detox. So what do you aim for in terms of, let's say, estradiol level for systemic protection? There's been some interesting literature lately because some studies point out that, women's estradiol should be 50, between 50 to 100. There are some other studies that are suggesting that no, we don't actually get systemic protection unless it's higher than that. And, systemic protection is, as you mentioned, the brain, the heart, the bones, and everything else. What are you aiming in your replacement?
I go with the 50 to 100 estrogen and 8 to 10 progesterone, but you have to understand some women cannot tolerate that.
That's exactly true.
And you're treating the person, not the numbers. So, when I can't raise your hormones to a level that gets to those numbers, I just let people know you may not get all the full benefits, but you're going to have a quality of life. You're going to sleep at night. You're not going to be gaining weight. You're going to preserve your bones, your brain, your skin. The studies on bones say that even the lowest dose works.
And I had actually seen it because I have, so most women that come to me, they either have coronary artery disease or they have risk factors for coronary artery disease, right? So obviously they're potentially in a higher risk group. But I also aim to 50 to 100. And you're 100, you're entirely right. There are definitely women who experience benefits at lower doses. There are women who need a little bit higher, and so the approach is we start low, we go slow, we certainly detox, we understand the genetic risk. We understand the cardiac risk because, as you mentioned, right, the whole inflammaging hypothesis, we go fairly deep into the cardiac risk so that we have the baseline and understand how impactful cardiac risk might be at the moment. Because, one of the things that Women's Health Initiative did tell us is that women with pre-existing coronary artery disease, especially the ones who are older, they may just be a different group, notwithstanding that the preparations used for all synthetic, they were not biocompatible or bioidentical, but still, we should do due diligence and assess women. And I have to tell you, I am absolutely floored by the number of young women who have subclinical coronary artery disease.
It's bad. Yes.
Bad. I got used to it, from young men, because it's sort of, we have a lot of literature pointing to this, some emerging studies, but we now have studies that are coming out, some observations, usually they're from Scandinavian countries where they have these fairly large cohorts that they follow. So, and we could see that, there is quite significant amount of women that have have subclinical coronary artery disease, and there is definitely a group of women who have accelerated atherosclerosis. I just saw a patient a couple of days ago in her mid-50s. Coronary calcium score is 456. So this is, so there are things that are happening that, are really giving us a pause. And I think this approach that you have presented is phenomenal. So, any closing words to our listeners?
I want to say you have to bring joy back into your life. That calms your nervous system down, and your nervous system affects your hormone system. So have some fun.
Have some fun.
So serious. I got to do everything on my to-do list. No, you have to have some fun. You have to have joy in your life and express gratitude. Even if you're in the worst mood, find something, one thing, to be grateful.
Love this.
Your heart, your nervous system, your hormone system, and your immune system. So have some fun. And I measure hormones 3 ways: blood, urine, and saliva.
So that's why I said, our listeners, this is a hormonal master. So Dr. Lorraine Maita. And by the way, if you're listening to us and you're not watching this on YouTube, I call you to action to at least see some of this episode on YouTube, because I want you to see how phenomenal Dr. Maita looks, because she actually practices on herself exactly what she preaches. And she looks absolutely fantastic. I'm not going to make you, Lorraine, to tell your age on the air, but she looks phenomenal.
I've been practicing for 40 years. So
40 years, and it shows.
I'm not a youngster.
But she looks phenomenal.
Right? Thank you.
You got it. Well, be well, everyone, and I hope you learned stuff from this. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Card Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticcardcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.